Welcome back to CURiE Conversations on the ACRO podcast. I'm Jenna Kahn, a radiation oncologist with the ACRO Science and Education Committee. Today we're discussing the article Dosimetry, Toxicity, and Outcomes of Medically Inoperable Endometrial Cancer, treated with definitive external beam radiation therapy and brachytherapy. Um, so I wanted to introduce our two guests today, and I'll let you both introduce yourself.
All right. I guess I'll start. I'm Dr. Scott Silva. I'm a radiation oncologist at the University of Louisville, and I specialize in treating GYN and GU cancers.
And then I'm Caitlin Reichard. I'm an M4 at the University of Louisville and applying to radiation oncology residencies this cycle. And I've been working with Dr. Silva for the past 3 years.
Fantastic. So, to both of you, I'll start with Dr. Silva. Tell me about your journey into radiation oncology.
Okay. Well, it goes back a little ways. So, when I entered med school, I was actually in the MD PhD program, and I did my PhD in an oncology lab. Specifically, my mentor, he was actually a surgical oncologist. And when I was in med school, I thought about doing surgery. Uh, I liked doing procedures, but I didn't love living in the OR, so to speak. And I ended up, I had friends who were a bit older than me who ended up going into radiation oncology, and they told me, say, hey, this would be perfect for you. You can do procedures, but you're not going to be called at 2 a.m. to do a trauma surgery. And you can also do research. You can do, you still do clinic work. So for me, it was a great balance. And then I ended up matching at Loyola in Chicago. And so I got a really great brachytherapy training there. I trained under Bill Small and Matt Harkenrider, and that's what really piqued my interest in doing brachytherapy. And then I ended up at the University of Louisville as an attending. So I've been here ever since 2018, really building the brachytherapy practice here.
That sounds wonderful. Thanks for that. Caitlin, can you tell us a little bit more about your experience over the last few years and how you found radiation oncology and, as you're applying into the field?
Yeah, so I originally heard about the specialty as a medical scribe for a hemonc. And so when I entered medical school, I thought I wanted to do hematology oncology. But during my first year of med school, they had a summer research program that students could participate. And as I was looking through projects, I wanted to see if there were any clinical projects as opposed to bench research in oncology. And that's where I found Dr. Silva, and he's been stuck with me ever since. But I saw that he had mentored a prior student, so I reached out to him about my interest, and the rest was history. As I spent more time with his brachytherapy practice, and then also like the clinic, I was really attracted to the balance that radiation oncology offers.
I agree with you completely. Since you guys have been working together, how and why did you choose this research topic?
So interestingly, the way uh, that this got brought up was it was actually about 3 years ago at Astro. So I also sit on the Astro uh, annual meeting committee, and I was asked to give a talk in the gyne section, and they actually asked me to give a talk on inoperable endometrial cancer. It was a little daunting because I was the youngest one on the panel. I was literally sitting right next to Kate Yashar, now the Astro president. It's like, okay, I'm gonna have to follow her. Like, so, but I prepped the talk. It was just an overall background, and then as I looked into it, I was like, there's really not a whole lot out there on this topic. So after I, came back from Astro, I looked at like our database. I said, what has our data shown? So we went back a couple decades, and even in a tertiary center, we only had less than 20 patients. But I figured, since it's such a niche area and it's an understudied but important area, I thought, okay, let's look into it. And then right around that same time, that's when Caitlin actually emailed me, said, "Hey, do you have any ongoing projects?" And I told her, "Yes, this is perfect timing, and we can look into, our results for our inoperable endometrial patients."
And then something I think that's also unique about the project, so, or I guess the area that we live in Louisville, Kentucky. So I just came from a rotation in Philadelphia, and they had mentioned that they don't see as many medically inoperable endometrial cancer patients. And I think the demographics in Kentucky make it really unique that we were able to not only see these patients, but provide brachytherapy at the university.
Mhm.
Can you tell us a little bit about getting into the article and kind of talking about this topic? Who who is an inoperable endometrial cancer patient? Who are these patients that you studied?
I think I can answer that one, and then Dr.
Sure,
Silva can correct me for anything
sure.
I get wrong. But my understanding is that the medically inoperable patients are those who can't do surgery for medically based reasons. So whether that be cardiovascular disease, pulmonary disease, um, veno thromboembolic disease, and increasingly morbid obesity with the way that the surgery would need to be done for those that would get the hysterectomy with the bilateral salpingo oophorectomy, which is a little different than if there were maybe anatomical reasons they couldn't get the surgery.
Yeah, yes. Generally, what Caitlin said that is correct. Basically, patients with significant comorbidities, morbid obesity, would be classified as inoperable endometrial cancer patients. Now, that definition varies from surgeon to surgeon. You could ask 5 different gynecs what their definition is or who they feel comfortable operating on, and you might get 5 different answers. So, what Caitlin said is like kind of the general textbook definition. But I have seen, if you go to different institutions, uh, different gynecs may feel more comfortable operating on, a patient, for example, who is morbidly obese, whereas that same patient at another institution, the gynecs may not feel comfortable operating on them.
Is there anything specific about the patients that were enrolled in your trial or your retrospective review?
Basically, these patients, I mean, they basically fell in that category, patients who are generally morbidly obese or had significant comorbidities. Um, and they were basically all deemed medically inoperable, which is different from surgically inoperable. So not the patients who, who we would treat similar to cervix cancer because they had such extensive disease. These are patients, had they not had those comorbidities, they would have been operable candidates.
It looked like from the table one that the median BMI was pretty high, so
Yes.
it seemed to be probably pretty prevalent in your population.
Hmm.
Yeah, the median BMI was 50. And I remember going through the database, and there were some people that were in the high 300 pounds, and I think even maybe one or two 400 pounds.
Tell us a little bit about the radiation treatment options and then what your patients, how they were treated.
Um, so, uh, So these patients were treated by different rad oncs because we went back all the way to 2009, so well before I was practicing. So, but these patients were generally treated with external beam radiation, usually to 45 gray to the entire pelvis, and then they received a brachytherapy boost with a Y tandem applicator. Um, Now, the dose regimen for brachytherapy did vary because we had different rad oncs who were treating this cohort of patients. But generally, the way I treat is I do 45 gray and 25 fractions external beam. And then the brachytherapy boost that I give is 17 gray and 2 fractions.
And just out of curiosity, how is brachytherapy for these patients? They're medically inoperable, often sometimes have some medical comorbidities. What type of, anesthesia, sedation, how are you implanting them?
So we are doing general anesthesia. And they definitely, they're getting clearance from the anesthesiologist beforehand. And that's a good question. That's a good point because that's one of the main reasons why I only like to do two fractions. So basically, the way it works is we'll keep them overnight with the implant in place. So they'll have the implant in place in the first day, the morning of, and then they'll have fraction one. And then the next morning we'll do fraction two, because I really don't like to have these patients stay immobilized any longer than that. And given their comorbidities, I really don't like having them come back for another implant procedure that requires anesthesia.
That's a good point. Tell us more about, the radiation, what you guys found in terms of the symmetry and outcomes for your patients.
I can touch a little
Okay,
bit on the outcomes, and then Dr.
sure,
Silva can take away the radiation aspects.
sure.
So we looked at overall survival as well as recurrence-free survival. And across 2 years, the recurrence-free survival rate was 67%, and the 2-year overall survival was 82%. And we found that all of that was comparable to the rates reported in the literature. We also happened to find a statistically significant association between longer total treatment duration and decreased overall survival. And then in terms of toxicities, most patients experience no acute toxicities. So 84% had reported no vaginal toxicities, 42% had reported no GI or GU toxicities. And then regarding late complications, patients also did really well there. So less than 20% of our patients experienced acute or late grade 3 toxicities.
So yeah, in terms of the dosimetry, so table two of the study, basically we averaged all the dosimetric values, looking at not only the target but the surrounding OARs. And basically, what we found was the OARs were within the standard constraints that are typically used for cervix cancer brachytherapy, based on the Embrace data. Specifically looking at D2CC values to the bladder, small bowel, sigmoid, and rectum. Um, and we found that, with that being the case, that the toxicities were fairly limited in this patient cohort.
And I noticed almost everyone was treated, or 17 of the 19 were treated with a Y applicator. Do you ever use more than just the Y applicator? Or it looks like maybe one patient with tandem and ovoids and one with the tandem and cylinder.
Yes, so if we cannot get both tandems in, yes, we would resort to another applicator, like just a single tandem or tandem and ovoid. Ideally, like to have the Y tandem in there to get better coverage. Uh, I know, like one of the reviewers asked, are we using any other applicators? Unfortunately, we do not have a triple tandem. And I've heard that it's actually I've seen it once. I saw it once in residency, and it looked very, very difficult to place. Um, I actually remember I think it might have been Bill Small placing it, and even he had a tough time placing it. So, but it would be ideal because we could get better dosimetry, obviously, with a third tandem in place.
I've even just placed a needle, I mean, just through the middle of
Yeah,
the Y, and so you can get a little bit of dose,
yes,
kind of like a
kind of like like an
another tandem.
interstitial.
You got it, yeah.
Yeah, we actually have done that for I have done that for some patients. They were not included in this study, but that is something that we have done in the past.
I wanted to make sure there was anything else part of your article um, that you wanted to highlight.
Um, so Caitlin kind of mentioned this already, but one thing we looked at was, looking at how the total treatment duration affects survival. And similar to what we've seen in the cervix cancer data, with a longer treatment duration, there was a decrease in overall survival. And that was shown in table 4.
So from that, is there a specific number of days or length that you try to keep or recommend folks to try to keep from start of external beam to end of brachytherapy?
So based on this data, we don't have a specific number just because we only had 19 patients. But generally, I follow the cervix cancer data, try to keep it within 8 weeks.
We've kind of gone through this a little bit through talking about it, but are there other suggestions or thoughts that we should take back to the clinic and use in our day-to-day setting from this?
I think, well, one thing to consider is that definitive radiation uh, is still an option for patients who may not be operable candidates. Um, Also, I guess you want to the way I think about this is to treat them similarly to cervix cancer, except we don't need to go to as high a dose as we do with cervix cancer. Obviously, we don't need to get to that 85 or 90 gray, which probably would not be achievable with the applicators, at least the applicator that we use in this study. But one thing I do want to point out, speaking of applicators, is and this was mentioned in the discussion, is one thing actually we're currently investigating is looking at the use of steerable needles, and that could help specifically in this patient population, especially those who have basically widespread involvement of the uterus, and trying to treat that entire uterus. If we can actually steer the needles to the fundus, especially with the patients who have very anteverted or retroverted uteri. So that's something we are actively investigating here at the University of Louisville with our colleagues in engineering.
Great, I can't wait to hear more about that in the
Yep.
future. I think your paper was fantastic. It's a
Thank you.
great addition to the medically inoperable endometrial cancer data. We're always looking for more of that. And so thank you so much for publishing this.
Oh,
I want to thank our two guests, Dr. Silva and Caitlin, soon to be Dr. Reichard. And stay tuned for more CURiE Conversations.
thank you. Appreciate it. And thank you, Caitlin, for all your hard work on this project. It really paid off.
Well, I couldn't do it without Dr. Silva's great mentorship. Thank you for having us.